and movement analysis, exercise and reflex philosophies and techniques at present. He is also an international DNS, dynamic neuromuscular stabilization instructor. He has been in private practice in Chicago since 2000 and continues to teach various seminars throughout the United States, Canada, Europe, and Asia. He is a very wonderful teacher, I should say. I have attended his workshop. He is very humane and I mean, down to earth, and he shares whatever he has in his heart and mind. So we welcome you, Dr. Robert Lardner. We are very privileged to have you.
Thank you so much.
Yeah.
Thank you. Thank you for inviting me. I am really honored to have been asked by you to come and give this talk, which is very dear to my heart because it is the basis of what I do for most of the time. So without further ado, let me get my screen up and let me share the screen with you, and I need to be able to, you have to allow me to share the screen.
So Robert, you can.
Okay, so if I go to.
Try now, Robert. I think you should try now.
Okay. Can you see the PowerPoint at all?
No, you need to go to share screen.
Okay, I will try it again. Ah, yes. Now it's working. Okay. 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 So, is that now visible?
Yes. Yes.
Yeah.
Okay, great. So, my talk today is about dynamic neuromuscular stabilization. And it is really looking at what children can tell us about movement. And this is just a small introduction into the course series and the implications for rehabilitation. Dr. Collage, who is the founder of DNS, is a physiotherapist himself. He works at the second medical faculty of Charles University. And he has been a pediatric specialist for a long time. And it is through his background that he was able to utilize concepts that came from originally the Voiter and German schools to develop the DNS, dynamic neuromuscular stabilization. And DNS is really a concept of how developmental kinesiology...
Sorry to interrupt, Robert. Can you go for full screen?
Sure.
Make it a slide share, full screen, please.
Okay. Okay.
Slideshow, yeah.
Okay. Okay. So
that's better.
The concept of developmental kinesiology is really looking at how we acquire motor control skills from a neonate to the first 5 years of life. Because this is the basis of building blocks for motor control and for the acquisition of locomotion skill and fine motor skills. We can use this information, as you can see here, that this child's position in squatting relates to this adult's position. Climbing relates to climbing. Uprighting relates to climbing. Sitting is also an acquired posture that comes from central nervous system maturation. The DNS principles are factors that they bring to the table of rehabilitation. One is that it describes the ontogenetic movement development. It describes what happens from the newborn to the upright, standing 17-month-old or 2-year-old baby. and then continues to analyze how this movement is matured and what it has for implications for adult movement and also for adult problems, or even pediatric problems. It also describes the idea of joint centration, which I'll come back to. It describes the use of the diaphragms, both respiratory and pelvic diaphragms, and even the glottis as producers of intra-abdominal pressure, which is essential for the stabilization of the torso. It also describes points of support, which means supporting areas of the body when we use them in order to anchor ourselves for movement. This is important when we are trying to re-educate muscle function, when we are trying to improve posture, and when we need the patient to not escape from an exercise, for example, and I will demonstrate that in a little while. It also describes the direction of muscle pull. In rehabilitation, we often speak of open chain and closed chain, but it is more than that. We have to know that in open chain, the direction of muscle pull is towards the proximal joints and the proximal anchoring site, as opposed to closed chain, where the direction of muscle pull is towards the distal anchoring site. These are very important factors when it comes to helping patients become more efficient in movement choices. And it also shapes very much the kinds of exercises we choose initially for the clients, for our clients. It also gives us a system of analysis and exercise prescription in terms of the planned movement pattern which we observe in children. And last but not least, it describes the reflex points which are used in Voiter, the Voiter approach, but here we use them to emphasize support areas to help us know how to guide a patient in movement and to give them kinesthetic feedback. The interesting thing is that we are not like the butterfly. We, at each stage, acquire more and more information about our movement possibilities and complexities. So our analysis of what is going on here at this age is linked to what the brain has acquired from the beginning. Unlike the butterfly, you cannot predict movement of the butterfly from the caterpillar because they are two absolute different animals. And they are linked only by this amazing transformation into the butterfly through the pupa. So we can see key milestones that are achieved more or less universally by all children. That around 3 months, we have basic sagittal stabilization. Around 6 months, we have learned how to turn. And by 14 to 16 months, we can verticalize and we can shift our weight from side to side with ease on the lower extremities and so on. We can see that these developmental positions can also give rise to adult positions that mimic them and give us access to relearn and retrain muscle chains in these positions. The anatomical norms are very well defined. It means that we can see that the local shapes of bones, the regional relationships of segments, and the overall global relationship of distant segments is quite fixed within most animals. This is because the biomechanical distribution of forces has to be efficient and non-damaging to the structure. So we can always identify a human bone as opposed to one of a kangaroo. We can identify the femur of a human as opposed to the femur of a cow, because we know that the biomechanical functions and the use of that bone is different and it is adapted to its function. And it also, by its very shape, defines what it can and cannot do. So when we look at posture, we can often wonder where it comes from, and there are many schools trying to describe posture and define it in terms that are useful for rehabilitation. However, many times the postures that are described are either just standing or sitting. We use a plumb line, and we tell people that they're either standing straight or they're standing crookedly. But this is not enough, because posture is constantly changing. Most of us don't stand on both legs equally all the time. We choose one leg, it's our favorite leg, and we stand accordingly. So there's a certain asymmetry of posture which we have to respect, but which we also have to pay attention to, because if it becomes too fixed within the system, it can become limiting. If you only stand on your right leg for a long time, and often as a habit, your left hip will be a little tighter. It will be harder for you to switch over to your left hip when you need to do it, and on those occasions when it is required. So how do we find out what posture really could be? Here we see how the torso is stabilized by the muscular system. Yes, and we can see how we can use the stability. The gentleman uses the belt to help him create intra-abdominal pressure, and he maintains the alignment of his spine within a narrow range. On the other hand, we can see in ballet, for example, that the movement that we require for the athlete here is quite different. She uses her spine in a very different way, and allows a much greater range of movement during her activities. So we can see that the extension or the mobility is very highly prized. The dynamic range of motion is highly prized in certain sports and in certain movements. So posture is not defined because it is a difficult concept. We have Pilates approach, we have Brugger, we have Alexander approach, we have many approaches where they try to define what posture might be and how we can achieve it. But from the DNS point of view, the posture is a genetic result of central nervous system maturation. We can see that the brain interacts with the skeleton, it interacts with the muscle, it develops function, and these speak to each other, finally determine what the posture will be, what the segmental alignment will be like, and what a range will be available. This in turn affects the motor tone, as you know, and we can see always that when there is damage to the central nervous system, the structure is affected. We see that in cerebral palsy, for example. We see that in stroke, and so on. So we can tell that posture is not something that is worn like clothes on top of the musculoskeletal system. It is a byproduct, and an ever-changing and responsive byproduct of how the central nervous system interprets the incoming afferent information. So our posture changes according to the information we are receiving. And the habitual postures we have are a result of habitual decisions about that information. We know that motor control varies through consecutive attempts. However, the central nervous system prioritizes a certain motion that is friendly to the structure and function of the segments and the limbs at that time. And we can see that, for instance, we don't walk sideways naturally. It is not efficient, it is costly, and you never just see somebody get up and walk sideways, because they inherently know that walking forwards and backwards in the sagittal plane is the most efficient way to get around, and the central nervous system chooses that. Of course, these movements can range from clumsy to quite refined, and we can see that the average person without specialized motor skill falls in the middle of this bell curve. And so the CNS development is reflected in the quality of postural acquisition and function. So we can see that posture is not static at the plumb line. It is useful to use that because it shows you the resting distribution of center of mass and weight, but it is not so useful when it comes to dynamic function. Posture is both a dynamic and static, and it precedes movement. It follows it like a shadow. And therefore, its quality is dependent on how the brain developed and what instructions it gave in the formative months and the years of childhood. How do we define a neutral joint position? Well, you can see in this gentleman that he's not standing at a plumb line. He is in full activity. But when he is in ideal posture, the relationship of his joints are maximally in contact for that position he is in. It is not a so-called close pack position, but it is the closest packed position he can get for that position alone, because that spreads the distribution of forces through the joints and gives immediate and effective feedback to the muscle system about what the next plan are and how good the stabilization function is quality-wise. So when we look at DNS, we try to reproduce natural, ideal relationship of joints in the adult or in the injured patient or child, and encourage the brain to remember what this ideal position feels like, and also how the muscles are activated. So there's a strong kinesthetic quality to the exercise. You cannot give the exercise and walk away initially. You must be there to help the patient have feedback about the muscle activity, the position, and most of all, importantly, the kinesthetic awareness of the posture involved in the movement or in the holding pattern. So here we see 4.5 month, 5 months supine position, and we mimic the same thing. Or here, this 4.5 month prone, and because of the different lengths and segments, we have a slightly modified position. And here we have sitting position. You see how natural it is without coaching. The baby understands from the input, the afferent input, that this posture is relaxing for it and efficient. And we try to restore that in the adult human. So not only does the joint centration allow for distribution of a load and avoiding injury to the articular surfaces and so on, it also allows for the muscle system to predict effective motor strategies, and therefore decide which muscles will pull maximally, which ones cannot, which ones will be inhibited, and so on. So we can see always the relationship between joint position that is ideal or not ideal, the available range of motion of that segment, and the muscle activity and tone around these kinds of positions. So functional joint centration is not defined by a specific position, but varies throughout the phase, but we almost always define it as ideal or not ideal, depending on not only the form or structure at the time, but also because after performance, we can assess the resting tone of muscles and we can get information, data about whether the posture or activity has been strenuous to the central nervous system or not. This is very important, that we always have some kind of audit for our interventions. We must always know what was before and what is post, because without it, if you're not assessing, you're guessing. And that is the words of Paul Chek, and this is very true. So we can see the spontaneous maturation from the newborn with the high shoulders and the diastasis to 3 months with a good stabilizing empty to hold the legs above the surface. Here in prone, we see no ability of anti-gravity function of the limbs. All lifting of the head must come over the extensors, and there is not sufficient intra-abdominal pressure and activity to anchor the movement so that it is steady and controlled. And yet at 3 months, we see spontaneously a different posture, a different amount of control, supporting through the arms and a steady head, and therefore the eyes can focus. So for the eyes to be able to move and focus, the head has to be still. For the head to be still, the ideal position is support through the arms and the pubic symphysis. So we can utilize this when we are training, for example, someone who has whiplash, and we need to find a better posture for them. Then we use support through the forearms as an assistance to the brain to remember how to anchor the head to the torso. We can also see that the diastasis is physiological in the young newborn, but it is pathological in the older population, because through the normal activity of the CNS, the diastasis should close, and the efficiency of the abdominal wall and the whole thoracolumbar cylinder should become such that it shows and demonstrates efficient function. If you do not have efficient function and the muscle pull does not go towards the linea alba, but the muscle pull is pulling away towards the ribs or the pelvis, it will pull apart the linea alba and create a diastasis. So we can already see that this is a pathological form, and it is directly linked to poor muscle decisions and locomotor execution from the central nervous system. This is not just a local structural deviation. So we can see throughout that the milestones that are met serve different functions for the child, and we have in turn to respect those functions, and we can utilize these positions for training, both conscious and reflexive training of our clients. We know that there are different reasons why we get postural disturbances. They can be anatomical, visceral, neurological, they can be functional, they can be nociceptive, and they can be psychological. When we look at the developmental kinesiology, we are looking at how well initially the sagittal plane stabilization takes place. For that, we need ideal coactivation of the whole thoraco-pelvic cylinder, utilizing muscles. And we can see that this same position is reflected in this weightlifter's position. It is the same strategy, but with different support. On this, the support is on the spine. On this, the support is at the legs, at the feet. we can see that the structure of the torso and its mobility and stability is maintained not only by muscle function, but by respiratory function, the ability to create intra-abdominal pressure, the ability to create thoracic pressure through breathing and breath holding, because these keep the health of the intercostals and the mobility of the joints current and maintains them for a dynamic and static use. The diaphragms, as you know, serve three different functions, and they automatically come into play as the child matures. And we can see that the respiration is first, stabilization is second, and third is sphincter function, which comes later. And therefore, we have babies who cannot control their sphincters in the beginning. So the ideal respiratory pattern should be a full costal breathing, meaning that you can see the movement occur all the way from the manubrium to the pubic symphysis, and all the way around. There should be ideal functions with the physiological movements of the ribs. Dr. Levitt said if breathing is not normalized, it is very difficult to improve any other movement pattern, because it is really the basis for anchoring the movement of the extremities and the control of the head. So we can see here that if we have ideal activity, we have a certain predilection to eccentric activity of the canister, whilst when we pull in or have concentric activity, we compromise the diaphragm's ability to descend. We force concentric activity on the muscles, which is more demanding, and it can lead to instability or what you would call uncontrolled movement in areas that we don't want. So we can tell from observation whether we are having a more ideal activity of the abdominal wall or if it is not ideal. And you can see here that even amongst both sexes, we tend towards especially if we train selectively the abdominal wall in phasic function or for aesthetic purposes, we can easily disturb this balance between the antagonists and the synergists of the torso, and we can develop valleys and rivulets and divots where they shouldn't occur. The abdominal pressure from the diaphragm descending helps to stabilize the torso. Here in the open scissor syndrome, we often see the weakness of the abdominal wall and compromised respiration with overactivity of the erector spinae. This often leads to unwanted muscle activity, which in turn will often damage the disc because the axial force, and that is often the cause of tissue damage around the spine. The developmental process is divided into three phases within the first year of life: the sagittal stabilization, the differentiation of extremity function within global patterns, and the developmental of locomotion and the verticalization. So to talk about the global patterns, we can differentiate really two main patterns. Those are ipsilateral and contralateral patterns. The third would be the homologous pattern of squatting or reaching, pushing, pulling with bilateral upper extremities. They are not particularly locomotory in themselves, except if you're hopping. But we can see that trunk stabilization, again, is an absolute basic requirement for the purposeful movement of the extremities. And here you can see the exercise is nothing new, but we are going to take cues from what is expected at the 3-month supine position and transpose it on the adult. It means a stabilization of the thoracolumbar junction and so on. And you will see that in a short video when I get to that. So we can see certain milestone positions, each of which carry with it a certain lesson or lessons of posture and movement quality that the child must assimilate or adapt. The ipsilateral pattern is one of turning. It requires an ipsilateral axis of rotation, and the muscle pulls towards the axis and helps to turn the baby initially. We first see undifferentiated extremities in turning, and then later on we see differentiation of extremities in turning, which we still see in the adult. For example, if you see someone pitching for cricket and they run up to pitch, and we see this same function around one ipsilateral axis. So this is interesting because then we can use these rules, for example, for training someone who is having problems turning. The ipsilateral pattern can also be seen here inside a sitting. And so it is seen also in sport, in golf, pitching, basketball, dunking, when you dunk the ball into the net, etc. The contralateral pattern, on the other hand, is one of locomotion, is our common locomotory pattern. And we can see it here where the limbs are doing diagonally opposite activities. So we have extension and extension. We have flexion, flexion. We have flexion, flexion, and extension, extension diagonally in the limbs. You can see that unlike in the rotary pattern, we have flexion and flexion on the same side. So in turning, the limbs perform, the same side limbs perform the same or similar movements. In contralateral function, the diagonal limbs perform similar movements. As far as muscle direction is concerned, when we look at muscle function, of course, we know there's concentric, eccentric, isometric activities, but the direction of muscle pull in any one of these forms is important to know. For instance, if I have my hand is fixed against a resistance, the bicep will pull towards my elbow joint. When I squat, my quads pull towards my knee and then towards the tibia. When I am in open chain, it is the opposite. So this slide is, so this arrow would go the other way. If this was open chain, the bicep pulls towards the glenoid cavity. And if I were to extend my leg in sitting, the quad would pull towards the pelvis. It means that the direction must be finely tuned by the central nervous system so that it is well coordinated and it doesn't pull at joints or segments in an uncoordinated fashion. For instance, we can see here that at the pubic symphysis, if the stability of the pelvic ring is not sufficient, the muscle pull of one set of adductors towards the fixed point on the ground and the muscle pull of the other set of adductors towards the pubic ramus will twist the pubic symphysis and can cause pathology over time, either traumatic or a repetitive injury. So so we must know and analyze in movement what is the direction of muscle pull, and what is its effect on the anchoring segments and the overall stability. Without this ability, we are left guessing what we should do. But if I can analyze this, then I can make educated decisions about what leg needs to be fixed during an exercise, what leg needs to be the open chain function, etc., etc. And this can be very important when it comes to more complex functions. So here we have some DNS tests, which I used initially to assess respiration and to assess the stabilization quality. I will show you just a short bit of a test here, which I filmed. This is really trying to look and observe how the patient is breathing. If I have mostly craniocaudal activity, or if I have a good excursion of the ribs. You can see he is a little nervous, so he is breathing up and down. But I can now palpate to feel how much excursion I get. If I don't feel much excursion in relationship to the excursion or expansion in the other parts of the chest, then I would make a note of that. But I should feel where I should feel eccentric distension of the soft tissue between the bottom of the rib cage and the pelvic rib. These are the indirect good descent. As the descends, it will push viscera downwards and outwards, and this will in turn excite eccentric activity of the abdominal muscular corset. It is this that I must be able to assess. We can also do it from the anterior. You can see that he is holding himself and he has these little dimples at the sides of the upper part of the obliques in the front. This again is often quite common, especially when you have patients who train the abdominal wall in a phasic manner and start to use that strategy for posture. You don't have the relaxed posture barrel of someone who is using and distributing the effort throughout the whole muscle canister. So he is doing the incorrect version, and I would prefer the distended, opened version. So we can also use these positions, as you can see, for treatment. For instance, as I showed you, the function of this 4-month position really helps to train the first stabilization function of the shoulder, which is anti-gravity elevation of the thorax to the scapula. This is not often appreciated because we often start trying to get the scapula to approximate the thorax. But the brain first learns how to bring the thorax to approximate to the scapula when the elbow is fixed. And it can be very useful for training the ideal co-activation around a joint. So we try to train muscles in their physiological function. We try to have them automatically activate in the ideal stabilization function. And by doing this, we can see and lessen the risk for repetitive strain. So here I have my patient lying down, and I want to improve his shoulder or train the stability of the glenohumeral scapulothoracic joint. I can then go ahead and put him let me see. Yes, I adjust his position to get a variation of the 4-month model. The elbows are at the auditory meatus, and I make sure that he can feel that his pubic symphysis is load bearing, that he's not just weighing down in his on his umbilicus. I can then position the shoulder into a neutral position, and the neutrality, this would be poor. I need a smooth position of the scapula to the thorax, and then I can use the supporting point of the condyle of the elbow to remind his brain of what I need in order to have good stabilization. This is the fixed point. That is the mobile point. So it is free to move, and I can adjust that mobile point on the scapula so that it can find its ideal position. And then I can activate co-activation function by having him lift his head and bring the thorax to the scapula. So that is what you will see me do as I try. Yes, now he lifts his head. I check the tone, and I can see that the serratus anterior lower trap rhomboids are working well without overactivity of the upper traps and levator scapula. So, as I said in the beginning, we use an audit, meaning I can use passive range of motion. I can use trigger points or tender point chains. I do a scan of the whole body. I can do manual muscle testing, looking for inhibition. And I can also assess soft tissue quality, fascia mobility, the tone in the muscles, the tone in the skin, and also look at the spontaneous posture. This would be an easy clinical audit for me to use after treatment, so I can see what parameters have changed and if my intervention has been useful or not. Again, assessing and reassessing so that I'm not guessing. In the athletic population, we know that we need a high level of physical conditioning, which often includes such factors as endurance, power, strength, and speed. We often need a good postural foundation. We have high demands on force production. Therefore, the movement quality must be good. And the cortical function, the gnostic functions, the hand-eye coordination, kinesthetics, and somasthetics, all these things should be have to be of a high quality so that the execution of movement and the judgment and planning is good. We are often limited by physical constraints, how much our ligaments will tolerate, what our respiratory tissues are like, are they pliable or not? If we have ideal orientation of joints, or we have limited joint motion due to structural anomalies or just variations. All these end up making up a functional threshold, which means that we can only perform ideally up to a certain point, and then after that, we must start to compensate and adapt. The job of the therapist is to delay the compensation and adaptation for as long as possible. It means that we must minimize the high loads and extreme conditions that usually come with these compensatory strategies. They are not, it is not dangerous to have, they can be the decision between getting the gold medal or the silver medal, because you have to put in that fifth gear and get to your goal. And so compensatory strategies are a normal part of our function but they cannot be a constant compensatory factor, because they are tiring and they usually are not efficient, even if they are effective. So we must always distinguish between what is efficient and what is effective. You can have an effective movement, but it is very inefficient and very costly. So we have to look at athletes, assess them, videotape them, see what it is they do, assess them comprehensively so that we can know, one, have they got the basic stabilization building blocks in place or not? Because without that, no amount of cognitive training, no amount of repetition will replace the lack of kinesthetic awareness and the rules that we see in the building blocks that children demonstrate. There is always a pattern that we see in the ideal motor function in children that is reflected in the adult's function. Another important factor is the quality of relaxation. The ability to relax muscles that are not needed for a particular function is vital for longevity and resilience. So when we see athletes or even non-athletes who have a hard time relaxing muscles, we must intervene and let them get a feel for what activity is and relaxation is. If we cannot do that, then we will only add to the muscular load and overload of joints and the musculoskeletal system. So we have to respect ideal posture. We must respect the individual structural limitations. We must introduce training variability whilst keeping in mind the physiological rules that exist for the safety of the overall musculoskeletal system. And the functional cortical training is absolutely vital for sensory integration, because without this kinesthetic or aesthetic training, the decision-making by the brain will be out of kilter with the joint position and the muscle force. And that is often a cause for chronic pain problems and chronic movement pattern problems. So this is, so the training and loading must be adequate to evoke good body adaptation, but not compromise the quality of the movement. Barbara Headley was a PT who died in 2015. She did a lot of surface EMG studies. And one of the things she cautioned against was that we often start out patients with too much exercise. We give them too many repetitions because we realize how easily compromised the muscle system is when it is inhibited. So I sometimes give my patient only 1 or 2, 3 repetitions every hour, because if they do 5, if the muscle is inhibited and has no resilience, no endurance capability, it will switch off and the patient will revert to his compensatory synergists and complete the rest of the exercise, in which case he has not gained anything except wasted both our times. So it is important to keep that in the back of our minds, that muscles and muscle inhibition is a big factor. It is the first thing we must think of before we even think of weakness, because strength production is first. We must make sure that the neural connection to the muscle works. And this end plate unit, motor unit integrity is the first thing we must facilitate. If we do not do that, we will often spend a lot of hours giving exercises that will only bring about other compensations, even if these compensations are painless to begin with. So Training must respect the anatomy and the biological and neurophysiological parameters, and it must look for the optimal movement pattern quality. So in conclusion, muscles may be strong enough in phasic function, but they may lack postural stabilization function. The quality of that depends on the coordination, global coordination of the muscle chains. And therefore we must have ways of assessing and accessing these muscle chains through known positions. This is where the developmental kinesiology plays an important role, because the brain has already visited these positions in childhood, and that was what it used to develop its movement repertoire. So why not use an already existing movement repertoire to reinforce new cortical control, and also to reinforce the subcortical mechanisms that underlie the automatic function of posture and movement. So that is really the fact that core stability and movement stability is not defined by the strength of muscles alone, but by the interaction of the torso, interabdominal pressure, and the central nervous system. And that is how we end up moving. And children are a great example. They're an encyclopedia for us into that function. So I hope that that concludes my lecture, and I would be happy to answer any questions from here.
Yeah, thank you, Dr. Robert. It was a wonderful session. Yes, you spoke so nicely, gave an overview. In fact, this was a 1 week workshop when we did with you for DNS. So you put everything together and given the taste of it. Yes, as it says, no, if strength is everything, then bodybuilders would not have back pain at all. So
that's right.
So it's about as you said rightly, the combination of everything, the movements. Before we go to the next speaker, one or two questions only I'll take. Somebody wants to know.
Yeah.
Dr. Arshita wants to know: is there any book on DNS for further reference?
There are manuals, but they're working on a book. But what they have done mostly is to try at the website. There's a lot of information, and there's a library. There are video libraries, and there are articles, and they're trying to make a good video library, because you have to see these things. In a book, it kind of dies. It doesn't come alive that much. But I know that they're working on a book, but they are going to, I think, develop more the audiovisual aspects with videos.
All right.
We can use this for, yeah, sorry.
No, go ahead, yeah.
I just saw a question, how will we use it in CP children? What we do is we must understand, for example, that the CP child has a blockage with the movement planning and the structural limitations, but we can adapt the positions, these milestone positions, and use them to facilitate the muscle chains. It is beyond the scope of this talk to tell you in detail how it is done, but I would think if you go to the Rehab PS website, you will see more information about that.
Can you come again? Rehab?
Rehab PS.
All right.
REHAP, P for Paul, S for stomach.
Correct. All
okay.
Right. Thank you.
Yes.
Dr. Arti Prasad, our president, says, so improving the proprioception should be helping the muscular co-contraction, is it?
Very much so. You know that when you sit on your leg for too long and it goes dead, you can't stand up. because you cannot feel, you cannot activate. The better your proprioception is, the better is your incoming information, and this automatically improves the outgoing instruction.
Yes,
So
absolutely.
this is kinesthesis is the basis of movement. Whether you are dealing with, to me, all patients are neurological patients. Therefore, those principles that exist must be across the board.
Okay. One Dr. Vikram wants to know if the pelvis and sternum are not relaxing or not stabilized and can't relax, how can we make them relax?
We have different strategies. First of all, you can use manual therapy and breathing. That is, I would say, the two great ways. You must first find a position where the option to relax is the greatest. And you must find a position where the patient can feel the difference between relaxation and not relaxation. For example, you may have the patient in quadruped, hands and knees, and you let him relax his belly towards the table or the floor. And then you have him pull it in and you have him relax it until he can feel the difference. And then you can turn him over and do some soft tissue and have him again try to reproduce the sensation of relaxation with palpation so that he has feedback. These are some easy ways to start to get the patient to distinguish between activity and relaxation.
Okay, all right. Before we go into the next speaker, last question. Then we will take again some questions. So we'll go into go with Dr. Padmanabhan. But before that, Dr. Raj Kannan says, what is the operational definition of inhibition? How to identify whether the inhibition of a given muscle or the group of muscle is a cause or consequence of a given problem, especially in pain?
Yes.
Did you get the question? Yeah.
Yes, I can see the question. It is
all right. Yes.
It's a very this is the burning question, because the only way from a clean clinical point of view, you would have to read the surface EMG from that muscle. But from the but in the clinic where we don't have access to EMG, what we do have is manual muscle testing. I think one of the things that people often confuse is that the tone of a muscle that is inhibited is almost undistinguishable from a tone of a muscle that is in spasm. They both feel the same. Only one is not having much activity. It is locked in its tone, but not with EMG activity or much EMG activity. So one of the ways is to do what I call physiological muscle testing. It means I must test groups of muscles or chains of muscles in a given position to see if the patient is able to hold the isometric tone. If they cannot hold the isometric tone, I suspect there's an inhibition in that chain, and I can start to work locally or along that chain to try to wake it up. That is unfortunately right now the only way you can do it, because otherwise you need sophisticated equipment with you all the time. So palpation and manual muscle testing and often limited range of motion are the three things, hallmarks of inhibition: altered tone, limitation of motion, and an inability to generate force in time of need, meaning that the patient will not be able to meet your force when you ask him to. He will be uncoordinated.
Wonderful. Okay. So we'll hold the questions. So there are many questions coming up. Otherwise also. So you can answer it a little later. We'll hear it from Dr. Padmanabhan before we move into. So let me introduce Dr. Padmanabhan Shekaran. Did his MPT from UK. In fact, MSc PT from UK, Chief of Physiotherapy and Rehabilitation Services, Sparsh Group of Hospitals, Bangalore. He's a specialist in movement analysis for injury prevention and sporting performance. He's got 20 years of clinical experience specializing in musculoskeletal injuries from tertiary care hospitals in India. Published author with 18 international peer-reviewed publications, which includes Journal of Arthroscopy, Journal of Shoulder and Elbow Surgery, and European Journal of Orthopedics and Sports Traumatology. International resource person, conducted over 100 workshops for physiotherapists and sports clinicians across all major cities in India and abroad also, which includes UK, UAE, Malaysia, and Kuwait. He has conducted various workshops on kinetic control. He is the kinetic control master, is the movement scientist, and I'm happy to, he's an executive committee member of BPN also, and he's in the scientific committee. So we are happy to have him. You welcome, Dr. Padmanabhan. Mic is yours.
Hi. Good evening. Thanks, Naveen, for that introduction, and Robert for coming to our what we call as the family program. And I think you made my job. You made my job easy. You've kind of introduced some of the concepts which I'm going to talk about. So it's a job done easy. Okay, made easy for me. I'm going to share my screen, and I think it would help if I stop my video. I think so. So I'll stop my video and share my screen.
No, only say share screen.
Okay, it says host disable participant screen sharing.
Yes.
Host, can you please enable my sharing?
Dr. Dhananjay? Dr. Dhananjay?
Yeah, he's working on it, I believe.
Yeah, is it so?
I'm here.
Okay, all right. Oh.
Trying to find me.
I made you as a host, right?
Host disabled.
You are the host now. Padhu, try now.
Okay, I'll try again. Share. Yeah, I think it's going to happen now. Okay.
Yes.
Okay. Can you all see my screen?
Absolutely.
Okay, fine. Let us see slideshow. Is that clear?
Yes.
Yeah.
Okay, cool. Okay, I'm going to start from basics and then application for a clinical scenario, and we'll see how it goes. My topic is, of course, kinetic control, and what are the clinical applications of what you call as the movement health model. Okay. There are two takeaways from this talk, because I normally have three takeaways from a talk, but then it's 8 o'clock, so there are only two takeaways. Good. What is movement health, and how can we apply this model in clinical practice? I've used an example of low back pain, and because that's what Naveen asked me to do.
Yeah.
Okay, we'll start with the basic question. Why do we have brain? 8 o'clock Saturday night, we are sitting and then doing update, where we should be doing something else. So why do humans have brain? Now, this is not a question that I asked. This is asked by the movement scientist, a neuro movement scientist called Daniel Ulpert. I recommend everyone to watch this very informative TED Talk. Robert spoke about developmental kinesiology. What I'm talking about here is what you call as evolutionary biology or evolutionary kinesiology. So we're not talking about how a movement evolved from a child to an adult. We are going to talk about how a movement evolved from Homo erectus to Homo sapiens, or what we call as Neanderthals, and then to modern human beings who are all over the malls. So what is the premise? The premise is this: human mind or human brain evolved necessarily to actually move. We assume that it evolved to think and problem solve and all that stuff, but the primary function of evolution of a brain is essentially to move. Let us see what is a movement here means. Okay, just take an example. We're not talking about even the efficiency in walking, running, and all that stuff. At the basic level, you think about communication. Humans used to communicate with sounds, okay, and with gestures, which was understood by only a very small group of people or his tribe. Now humans communicate with millions and millions of words. And in this ability, if you look at it, is your ability to move your tongue and your facial muscles in whatever way you want. Okay, so brain evolved to produce purposeful movement. That's what it does. Okay, please watch the TED Talk, and then it goes about explaining in detail about this premise. Now, why did I set this up? Because we keep calling ourselves movement scientists. Okay, we'll at least be movement specialists. Let me say what we actually do as physiotherapists. What do we do in clinical practice? Why is it important? Now, we are part of the medical or healthcare system, and all medical specialties are based on anatomical or physiological systems. So if you know what a cardiologist does, you know what a neurologist does, what a dentist does, they all take care of one system. Now, what do a physiotherapist do? You can call, we kind of take care of all the system, but the world is moving towards specialization. You're either a specialist of something or you're not. So we have to be practitioners of choice. That means we choose and then deliver one area of the human physiological system. And that is essentially the movement system. That's what I'm here to convince. Why is it important? Because right now, you can see widely physiotherapy is practiced as a service. That necessarily means that someone else asks for what has to be done by a physiotherapist. It may be a doctor, it may be a patient. I'm not offending anybody here. Now, nobody goes to a dentist and then says, can you please remove my third molar? It's hurting. No, he just goes and says, I have a toothache. Now, the professional decides what to do with that. And we are not defined by our intervention. Nobody says an orthopedic surgeon, okay, can you please do this type of fixation? Nobody says that. Okay. So we are not supposed to be defined by the service we provide, but as a professional who deal with one of the physiological system, and that happens to be the movement system. Why is it important? Because unless the patients know what we do, they're not going to come to us for what actually we specialize in, but for everything. Now, is that good? Not going to be good. I'll tell you, if a patient has back pain, he goes to uncle, auntie, pharmacist, orthopedic surgeon, and then comes to physiotherapist who kind of treats the back pain with every possible intervention possible. And then we keep debating what is the best intervention. We should have standardized system of assessment and treatment, and it has to be underpinned by a physiological system. And that's when we move as a specialist. And that happens to be the movement system. Now, this is not me talking. This is our godmother talking. If you have already not read this paper, I would strongly encourage you guys to please have a look at this by Shirley Sharman, 2014. It's in the APTA journal. And it talks about how movement is the professional identity of the physiotherapist. And physiotherapists need to own the human movement system before it is taken over by athletic trainers and, whatever, strength coaches and all that. Okay. So human movement system should be owned by physiotherapists. We need professional. That means somebody who's going to refer you, because a cardiologist sees a knee pain, he's going to refer to an orthopedic surgeon. So we need professional recognition for what we do. We also need public recognition. Why is it important? That's when the patient walks into you directly. Instead of going to someone else, he says, okay, I know that physiotherapists do this, and then I have to walk to him. Okay, that's how you get independent practice. So that's exact words. That's why it is in apostrophes. We need professional and public recognition for who we are and what we do, and we need to own the human movement system. Now, there is a lot of work that is being done in the US, and there is a lot of lobbying and also a lot of advocacy to include movement system as part of the education. This is a series of at least 10 articles discussing how movement is going to be the future of physiotherapy education, undergraduate education. And then it talks about how it is already there in musculoskeletal practice, as you can see. Ability to observe movement, ability to correct movement faults, and then what you do about it. Interventions. Neuromuscular practice, it's already there. And this paper talks even about integrating it to the cardiorespiratory practice. Please read this paper. So the future therapist is going to come up with this skill set. What is kinetic control? It's essentially a clinical framework, and it's an integrated system of analyzing movement. That's what we do. It's a comprehensive system. We keep updating it every year, and the updates happen based on what is the evidence that has happened over the last year. And it's not a treatment technique. It's not an intervention. It's a holistic, it's a whole concept of dealing with the movement system rather than a single intervention. Now let's come to this concept of what I said in the title. What is movement health? Okay, I'm sure you've all heard about physical health. We are in the corona age. The physical health definition of WHO is even more relevant now. This is the 4th semester blue book. So physical health essentially is the state of complete physical, mental, and social well-being, not necessarily the absence of disease or infirmity. Infirmity is weakness. So if you're just not having a pain or disease, it doesn't mean that you're healthy. Somebody told me something very, very interesting. Are you fit or are you healthy? So just demonstrating ability to lift weights or run a 10K doesn't necessarily mean that you're healthy. So physical health has got parameters. And of course, it has to be tested various ways. As you can see, you do your blood test, X-ray for every part of your physical health, for your organs, and also for your systems. And nowadays, if you see, you don't wait for you to develop a disease and then go on get your health checked. You go before, you do what you call as the annual physical health checkup as a preventive way, okay? Because the focus is to prevent a disease or infirmity. That's where it's going on. And what is mental health? I think this is I think Robert would agree. The guys who you earn more and the guys who are most in demand are the shrinks or the psychiatrists or psychologists in the US, mental health. We don't see that amount of popularity among psychiatrists and psychologists among India. And you know the reason why? Because we have got our babas and gurus and whatnot. All the guys who actually essentially go there have got mental health issues. That's what I'm saying. Don't kill me. Okay, now jokes apart, what is the era of what you call as dental health? 1980s, people went to a dentist if you had problem with your teeth. That means you had toothache. Now people go to a dentist if they have tooth. They don't go wait for the toothache to develop. That's essentially what this is for one system. And look at what happens to movement. This is the era of what we call lifestyle disorders. And every lifestyle disorder is linked to the way we move or we don't move. Now you can look at this era as the era of not necessarily the healthcare. This is the era of healthy living and human longevity. And that's why so many people are running around in the in the weekends. You see so many marathons, so many cyclists. And that's why you see all the gyms filling up, and you will see tabs and different forms of exercises coming up. Okay. So, and every single of this have got movement, the way you move. And we are not talking about somebody who's moving and then getting injured. We are talking about somebody whom we can make without injury or prevent injury as they start to move, or they continue to move, or they get back to moving. And this is the era of movement health. So that's essentially what should be our focus. And that's a very, very big focus area for physiotherapists. Now the concept, before we go any further, let me say this. This is the argument, and this is necessarily exactly the same answer for this argument. Of course, there is no right or wrong way to move. I normally demonstrate this in the course by asking you guys to get up from your chair and then sit. I think you can do that now. So when you get up from the chair, okay, guys who are driving, please don't do it. So if there is no right or wrong way to move, okay? So if there are 126 people here, there are 126 different ways of moving. But is that what we are not going to label somebody as ideal or abnormal. We are going to say, identify, is somebody having movement problem, what we call as movement impairments, which I'll explain in a while. And can we do something about it, especially if it affects the efficiency by which you complete a task, or it leads to your pain. And this is a key therapeutic skill that a physio should have now, and most definitely in the future. Why is it? Because the pathoanatomical model is dead. I think time and again, we keep sharing this information that if you have this problem, Okay, disc is not necessarily the source of your pain. Same thing, you have a supraspinatus tendinitis, inflammatory pathology of the supraspinatus tendon. You need not necessarily do anything anti-inflammatory for the tendon, is it not? The patient has come to you after he has taken anti-inflammatory medication. So there is no anti-inflammatory ultrasound over there. Okay, so what we are looking at is essentially what we call as pathokinesiology now, because we know that this condition is associated with scapular dyskinesia or scapular movement faults or humeral movement faults. But what you're proposing is what you call as the kinesiopathology, where someone like an overhead throwing athlete who doesn't have shoulder pain now, you can tell him that he's probably going to develop shoulder pain because his scapula is in a downward rotation or forward tilt. And that is what is all about kinesiopathology. And why is this important? Because we become what we call as lifespan practitioners, where we just treat anybody who has scapula, anybody who has back, not necessarily anybody who has shoulder pain or back pain. So, and then we treat everyone who's moving, right from the child to somebody who's not moving. And that's the scope of this model. So we do what we call as movement lifespan practice. And I propose what you call as the annual movement health checkup, like how you do annual physical health checkup for prevention of your physical health problems. You do movement health checkup in an industry. Now I said it's very common in sports. Okay, we do pre-participation screening and movement screens. Imagine somebody is going into a software industry at 23 years and he is going to be stuck there for another 23 years. And every year we know that his problem is going to only accumulate. So instead of you trying to check whether the problem for his back pain is coming from the chair or the desk or the computer, okay, we just give the ability of the back to sit and work in any chair and sit and work in front of any computer that it wants. That's the concept of movement health. And we have to look at the back, not the back pain. We have to look at the back and give its ability to sit and get up from any surface rather than fixing the surface. That's the concept. It has been defined, 2015 paper, defined very well. So movement health essentially is a desired state that is not only injury-free. You don't wait for an injury to happen, but a state which allows an individual to choose how to move. So essentially, that is the choice in movement or movement choices that we have. Necessarily, that is what defines what is movement health. Now, the example I gave you, so you have a back which can sit and get up from a chair. It can sit and get up from a park bench. It can sit and get up from a sofa. It can sit on an Indigo flight, and it can sit on a horse. So that is essentially is the choices you have. And you can see somebody who don't have choices. You have back pain or you have a back and somebody has told you that you have to fix your chair and the choice is lost. He is carrying his chair or the pillow wherever he goes. The choice is lost. That's not a healthy movement. Recent paper, 2020 January, Sarah and Lincoln. So goes into detail about how to assess for these choices, okay, in terms of movement coordination. So we cannot look at movement as a whole and then say it is right or wrong. We can look at the components of movement. In here, we are looking at the coordinative strategies because that's what the science says and whether the choices are lost. Now, for that, we have to understand the multiple choices is inherent to human being. It's called as the motor abundance. It used to be called as the motor redundancy. Now it's called as the motor abundance. That's essentially Latash, which Robert told, okay, already. So how do we get so much abundant strategies? It's an interaction between a task and the environment in which this task is performed and the ability of the individual. Most of the time, we are looking at only the individual parameters like tightness in the muscle, weakness in the muscle. We don't look at the task and the environment. Now, if it is a task such as a ballet, okay, or a sport specific task where you have to minimize the amount of variability that you do and then keep repeating the same movement again and again and again with precision, then you have limited, you cannot really say you have limited movement variability. It is just that you have mastered this variability and you have minimized what you called as the motor cost. When you minimize a motor cost, okay, then you make the movement efficient because you're not using all the strategies available. You're using that one strategy. Now, why is this important? Imagine a patient who's sitting in front of computer, his neck moves, okay, with a posture, okay, which is ideal. His muscles need to work at a minimal motor cost, and then they don't become overactive, they don't become inhibited, they just work at the optimal level. We call it as low threshold, okay? And that's essentially what we are trying to restore by correcting the posture or restoring what we call synergies, and also restoring the ability of the head to stay on top of the shoulder in an optimal way. I'll just explain that later, but understand this task environment and the individual context of movement coordination. Can movement health be tested? Of course, again, a paper, assessment of movement health, I've taken. Now, this is to link the sports world and the movement world. There is quite a bit of argument and debate about how you apply your movement testing or movement screening to the sports world. They're fundamentally different. I think that's what we need to understand. Now, what we do is what we call as a preferred movement evaluation, where you look at how the patient is moving. For example, the example is you see somebody doing a hop test or a vertical landing test after an ACL, and then see that if he has got a dynamic valgus. Now, this can be a biomechanical problem, or it can be a neurophysiological problem. And this is exactly what Dr. Robert said. Now, if it is a biomechanical problem, it requires an intervention which is biased towards restoring the biomechanics. And if there is a neuromechanical or a neurophysiological problem, then the intervention should be biased towards this. And we have classified patients. For example, group A, somebody who has very good biomechanical strategy and also very good neuromuscular control. This may be a high performance athlete with variable skill, both strength skill sets and coordination skill set. Example, a CrossFit athlete. Okay. Now, if you are restoring a CrossFit athlete back to what he has to perform, his activity, now you will not be using a neurophysiological technique like muscle activation to restore this guy. Okay. You have to understand his primary problem may be in the biomechanical problem. Okay. So that's why you have to understand, and their ability, because they have very good neurophysiological ability, their ability to learn this skill is a little faster, and you can fast track this guy. And then the coaching and skill development is necessarily the focus here. Now, there are people who are biomechanically less advantageous, but they are neurophysiologically very skillful. These are activities which require you to control multiple joint movements quickly. And then it may not necessarily have biomechanical constraint. You can put yourself in biomechanically inefficient places, but you still execute the task. This may be the dancers. Okay, this is more of the aesthetic movements. Okay, when this person get injured or this person has problems, then they are managed differently. The injury may be because of the biomechanical problem, may not necessarily be the neurophysiological problem. And any neurophysiological task that you give this person is going to do it very well, while his weakness still remains in the biomechanical area. Now, group C is biomechanically good, but neurophysiologically not good. This is your gym guy. Okay, he goes and lifts. You tell him to lift anything, he's going to lift. But you ask him to do a sequential movement like a throw, okay, or you put him on functional training, or you ask him to do a CrossFit, he's going to fail miserably. Okay, now you know what the problem is and how to fix it. Okay, the focus has to be in restoring the neurophysiology. Now, group D is our patient who walks into your clinic. Okay, these are the patients who may neither have biomechanical potential nor have neurophysiological. And this is exactly why the cognitive neuromuscular testing fails so much. Okay, they fail in the movement control or movement assessment so miserably because they don't have awareness of both their joints movement, interlimb or segmental coordination, or a neurophysiological ability like your proprioception or cognitive control. And just by looking at this, and they are in pain, and then this is the most difficult group, and this is the most common group that come to your clinic, and we cannot take the intervention that we do in this and then apply it here, and vice versa. Okay, so that's essentially what this paper talks about, and that's how you apply the movement assessment, and that's where the critique comes from, because people don't understand this model. Now, in the bottom group, group D, Can it be tested like how you do your blood test? Of course, we call it as cognitive movement control test. Okay. And it is cognitive because it doesn't use any functional positions. We don't extrapolate to function, but we can extrapolate it to the cognitive control in terms of your proprioception, your cognition, your muscle synergy, and then movement coordination. So essentially, that's an example. It can be tested, but then it is for that group. We can also do a high threshold testing for these other three groups, which goes into the performance matrix world. Anyway, what are we testing? What are we testing as part of our movement health? What are the components of movement health? Primary component of movement health is essentially the ability to control a movement. So you are going or you're lifting your arm, you're sitting and then working in front of computer, and you want to control your ability to keep your head over your shoulder, your back on top of your thoracic spine, and your hamstring not to be pulling back, okay, and thoracic spine not flexing. So your ability to control the movement when we choose to is essentially one of the component of movement health. And that's essentially what we are looking for, the movement control. And you also display this ability to control at varying intensities. That means I can control my lumbar spine rotation when I walk. Okay, of course, when you sit, stand, walk, you are rotating your lumbar spine. And I can also do the same rotation when I kick a football, I can control, or when I do a golf swing. Okay, football, my leg moves on top of my lumbar spine, and a golf swing, my thoracic spine moves on top of my lumbar spine. So varying intensity, I can control just as walking. And variability, I have the ability to perform movement tasks with range of options. I can sit on a computer, sit on a sofa in front of a computer. I can sit on a chair. I can sit on a park bench. I can sit on a horse and ride. So it's the same back, same structure, but I've got variability in my system. I can perform any task, the sitting task in whatever environment it is provided, I'm required to do. Awareness, the ability to see and be aware when the body is moving. Why is it important? Because when you sit, you must be able to know where is your back in relation to your thoracic spine above, in relation to your pelvis below. And if you are moving and you're doing, say, a back kick, what you call the scissor kick in football, then you have to know the ball. You have to know the height of the ball, the speed of the ball, and then you put your body into a position and then execute the kick. Or you want to do a somersault as part of your martial arts or as part of your football kick celebration. You must know where the ground is, otherwise you're going to hit your head. And this is essentially all the components of movement health. If you're healthy, you're practiced for everything. If you're not healthy, you have just stuck with one aspect, maybe the low threshold ability or low intensity of movement health. So this is essentially all the components that we should look for. And that's essentially what is movement health about. So what is the kinetic control health model and how do we apply this in clinic? Of course, in clinic, your patient doesn't come and say, I have difficulty in somersault, okay? And we know what to do with this guy, is it not? He says, I have difficulty in somersault, don't do somersault. The problem is I have difficulty sitting in front of the chair, sitting on the chair. You say that, don't sit on the chair, okay? That's where the problem is. Because the problem is not his ability, we are supposed to restore the ability to sit on the chair. That's essentially what is our job. Not change the chair or not advise him not to sit on the chair. So how do you restore this? First understand, is there a problem with the way the patient moves? That's the movement impairment, okay, in current episode pain. Doesn't have, is there a problem with the efficiency? That means, Dr. Robert said in the last slide, you use a strategy that you use for lifting or pushing as a strategy to hold your posture, okay? So that affects the efficiency of movement, okay? So we call it low threshold and high threshold. Whether you use the task that is required for low threshold, where you're firing your muscle for 20% of the maximum voluntary ability, and then executing the task, like sitting here and listening here for 3 years, okay? Is it efficient? Muscle control of movement, the muscles both at the segment, above and below, all have the ability to control the movement based on the direction of movement, the speed of movement, the load of the movement, and then complexity of movement. Nothing happens without cognitive control. Every area in your movement system has a representation, and whether we are using the right representation to execute the movement. And I told you about the movement choices. Do you have the ability to do multiple movements as part of your health? And if you have problem in any of these, is that what is the cause for your pain? And is there a persistent movement dysfunction which causes this pain? And have you given a symptomatic relief now and then taken this episode of pain, but the dysfunction persisted? You did not address the dysfunction, and that's why the patient comes to you with recurrence. Okay, so you look at addressing all of this. That's essentially what is the movement health philosophy. I'll talk with the movement impairment first. Very simple one. What is movement impairment? Somebody has got problem with movements. There are only two problems with movements. There can only be two problems. Either they are moving less, which is a restriction in movement, or they are moving more, which is a compensation in movement. We call it uncontrolled movement. Now let's go and explore. If there is a restriction in movement, it can be articular. That means it can be in the joint. The restriction in movement can also be myofascial. And all your restriction will be compensated by a movement above or below or within the same segment. That's an uncontrolled range. Or you can have an uncontrolled range like a hypermobility without restriction. And you have an uncontrolled translatory movement in the joints, your lysis, your listhesis, okay, your subluxation, your translations. So that's all you can have in movement, in clinical problems with movement. Now, let's discuss in the context of a case scenario. So how do we apply this in the clinic? I'm pretty sure everybody is familiar. This is essentially all of us sitting now. Okay, I can go and make a prediction. If you guys are sitting, you are necessarily sitting in this position. Okay, the slouch. This is the human evolution. So you're sitting in slouch, standing in sway. Is that a clinical problem? Yes. Before we go into the posture, let's see how we apply the movement health model for this clinical problem. I'll just take this. Now in the course, I normally ask for a current management plan, but I will show you the system, how a management plan evolves. Question 1, who is this patient? Is this somebody who is sitting in slouch, and has to sit as part of their occupation and sustain it or repeat it? Or is this somebody who's sitting like this, but does activities such as golfing, does Pilates, does somersaults, okay, and doesn't have current episode pain, okay? Now, based on who is this patient, the management pathway will be different. Now, because we are going to talk about pain, I'll go along the pain model, okay? Now, watch this. This patient, the first thing that you should ask is, where is the pain? Okay, can this patient have neck pain, shoulder pain, back pain, sacroiliac pain, and hip pain, and an impingement? Everything is possible, okay? And each one has a different interaction, but we'll assume that this patient sits in slouch and then complains of back pain. Very common presentation. Where is the pain? Because the site of pain is the site of dysfunction. I keep saying this again and again and again. A movement health or a movement assessment model is very poorly misunderstood. For example, you try and treat a plantar fasciitis by fixing the hip. Okay, good idea. That's not what I'm proposing here. If there is plantar fasciitis, is there a problem in the foot? If there is no problem in the foot, then you go and look at the segment above and then the segment above. Okay, so if there is site of pain is back, look at the back. And then understand the pain mechanism. What is the type of pain? What we're going to, a movement-related pain is essentially a mechanical pain. How does it present clinically? It's an insidious onset pain. There is no history of trauma. Insidious onset pain. It's a static loading pain. I sit for half an hour and then I start getting pain. A repetitive loading pain. Every time I sit and then move my body on top, or every time I go into yoga posture, I have pain. And it is a chronic pain, and it can also be a recurrent pain. So that essentially is a movement-related pain. So then comes, okay, fine, there is a movement problem which I need to find and assess and treat. Now, Robert Laudner put it very nicely. The posture precedes movement. There is quite a bit, I see a lot of physiotherapists. I know it's a bad press. Posture receives a lot of bad press. It's because people misunderstood or poorly understood posture. What is posture? Like, as he said, it's the background on which you create movement. Okay, it's dynamic. Okay, for example, you are doing a somersault, the posture is evolving and then it is dynamic. So in this case, you're not doing somersault. You're sitting and working in front of the computer. So assume that the posture is what you call as the lumbar spine flexion posture. Okay. Why is that important? Because that will influence the way I move. Now I have a lumbar spine flexion posture in any activities that requires flexion. I'm sitting and driving a car, or I'm bending forward, or I'm standing and bending and treating a patient. My movement will have excessive flexion because the body takes the path of least resistance. So if I'm already sitting in a lumbar spine flexed posture, then I'm going to move excessively. Instead of a hinge, I'm going to move excessively in lumbar spine flexion. If I sustain it, if I repeat it, will I have symptom? 100% yes. That's the link between posture and movement. Now, what box does it fit in? Now, is there an articular problem, or is it a myofascial problem why I move like this? And is it a local problem where it's a segmental problem, or it is a global problem where I move the entire spine? There is a way to assess this and then the way to classify this. Okay, that's what I teach in the course. Now, what we look for next is essentially how is the movement control. It's good. You can have your flex posture, okay, and you can have your lumbar spine flexion, but can you control it? This is why somebody has a bad posture, but still don't have symptom, because the mechanisms by which you control the flexion is intact. You may be aware that you're going into flexion and then you correct it before it becomes symptomatic. Okay, you have the muscle control that enables you to control the flexion. Okay, that means your extensor stabilizers are very efficient. So look for movement control by moving, whether this flexion is influenced by the movement above of the thoracic spine or movement below of the pelvis. Now let us see clinically how is it relevant. When you sit and drive a car, okay, now you sit in lumbar spine flexion, you stretch your leg, and because of your hamstring, or not necessarily because of your hamstring, because of your lumbar spine, you go into a posterior pelvic tilt and the lumbar spine flexes. Now this may be a condition where the movement of lumbar spine is influenced by movement below. Now you sit and work in front of computer, there is no influence of hamstring. So irrespective of how much hamstring stretch or hamstring inhibitory techniques you give on this patient, it's not going to fix. Because when you sit and drive or sit and work in front of computer, it is the thoracic spine flexion that is inducing the lumbar spine flexion. So understand the interventions are different. That's why you have to look for the control. Once you look for the control, your intervention is to train the control based on where it is impaired by controlling movement above or below. So it becomes extremely specific. And for the control to stay, you are looking at also the muscles. And of course, we classify the muscles into the local stabilizer, global stabilizer, and global mobilizer. In this case, the muscle which has to be facilitated should be your lumbar multifidus, and the muscle which has to be inhibited should be your hamstring and your rectus, your TFL, and also your erector, okay, based on how they behave in this case. Look at the other factors. This patient may have chronic pain because there is central sensitization, and this patient may maintain the posture because of psychological factors. Okay, understand other factors involvement. Understand proprioception. Without proprioception, there is no movement. What is the proprioception? Proprioception is a bad meaning. It's a word which is used for everything. What is the proprioception that we are looking at here? We call it as kinesthetic repositioning ability. That means you know where your lumbar spine is in relation to your pelvis and thoracic spine, and you have the ability to detect when it moves towards flexion, and you're able to put it back every single time that it goes out of neutral. Okay, so we assess for kinesthetic repositioning ability and kinesthetic repositioning accuracy. Now, when there is a recurrence, you also look for local stability. That essentially is what is said about your abdominal core, the inside core. You have to look at the local stability in terms of segmental pathology. You have had a huge disc with a history of huge disc, history of surgery, your local muscles like multifidus, your transverse abdominis is inhibited, and you have to look at that. Now, movement also has to be integrated into what we call high and low threshold. Low threshold movement, I have back which flexes and I become symptomatic when I do sit, stand, and walk. I have a back which is symptomatic when I do somersault, kick a football, or play golf. So those are high threshold options. So the intervention is different than low threshold and for high threshold. That's essentially how you apply this in the clinic. So there are so many questions, and that's where the question starts, and that's where the intervention. And we have not stretched anything. To summarize, this is what I've been saying. Physiotherapy is not a service. I think everybody agree with that. Physiotherapists are professional. We do deal with movement. We move away from pain management, because anybody can manage pain, to what we call as movement management, and a pain which is associated with movement. And we don't treat back pain, we treat the back. We move away from anatomical structure. I didn't speak about disc. You don't talk about tendinitis. Okay, we treat the system. Okay, that's when we become specialist of the system. We start treating a patient who has a problem with movement, but we have the ability to treat anyone who moves. That's essentially movement health, and we restore those choices. Two takeaways: movement health. I guess you got the concept. And how to apply this model. I just gave you that model in back pain. We can do this model in neck pain, shoulder pain, or even Achilles tendinopathies, or any part of the body for that matter. Hope you guys enjoyed. Thank you. Are we done?
Yes. Wow, amazing, Dr. Padmanabhan. I think there was a sync, or it is called as sync between you and Dr. Robert.
Yeah.
So you both spoke about a movement, and the sync was very good. Dr. Robert, you are there? Dr. Robert, is he been unmuted? Okay. May I reiterate, Dr. Padmanabhan is a pistol squat specialist. Amazing you do. No, the control that you had, and so that was amazing. So we all, yeah. So Dr. Robert, are you there? Dr. Dhananjay, Dr. Robert, can you unmute Dr. Robert if he's there?
Yeah, I think I was the host. I muted him.
Oh, okay. Dr. Robert, you're there?
Yeah. Yes, now I'm here.
Yeah. Okay. You want to say anything about Dr. Padmanabhan presentation? So overview of it?
Oh, I think, it shows that rehabilitation and, as you said, movement health is a continuum.
Continuum, yes. Exactly.
You have building blocks that you must ensure exist. And then you have assessments that tell you about how does the person use this system, like Dr. Padmanabhan has said. So I think that when you look many times at these approaches, they kind of meld together. Your decision is, where do you put your emphasis? And from your background, what you're going to use in your tools. I think that, for example, I spoke about the inhibition. Inhibition is not something you can always train away. So you need to have an intervention for inhibition. If the patient has a inefficient respiratory strategy, that is also something you have to take care of on the side. So I think that it's an excellent, I like Shelley Salmon. I've met her a few times. I like her work. I like the idea, and I integrate these when you are putting together the whole rehabilitation process, because that is where you are going to look at all these factors and start picking out and prioritizing what is going to end up being the rehabilitation process. Yeah.
Oh, wonderful. Very good. Dr. Padmanabhan, you have a few words?
No.
In reply to what
this is good. I think I really enjoyed speaking alongside Dr. Robert. I think he kind of made my job easy. The prime warm up was done, so it was easy for me. And then, as you said, there was a good sync, and then movement is the key word. I think BPN has done a great job in bringing this movement message to everyone. I think everybody's going to take that movement message. I think that's the future, I believe. Okay.
Because, for example, whilst there is no wrong movement, we can always decide if it is efficient or not. That is the key. Yeah. And then from there you start to have an intervention. So I think that is really, it's exciting because we have moved forward from just exercises that are driven by protocol. This is the worst we can do, is to have protocol-driven exercise.
Very rightly put in the end. Yes, very nice. We have cocktail dinner in the end, so nobody leaves. So, Dr. Dhananjay, can we have a few seniors and few people to interact?
Mohana Krishnan to say something from Pondicherry.
Yes, please.
Sure, you can unmute. Dr. Mohana Krishnan is the junior most physiotherapist in Pondicherry. Yes, sir.
Does he know that?
Dr. Mohana Krishnan, your views on kinetic control.
Yeah, it was wonderful to have Padmanabhan speaking on kinetic control and Robert to speak on DNS. It was excellent. It was it really made a lot of difference, and it showed a class. And hats off to BPN. And of course, I would like to thank COVID-19 for making this possible. We are in just because of COVID, and not in the right sense, but we are glad to have you. Ati Prasad has got something there. Yes, madam. Sorry?
I want to say something. I thought both the speakers were fantastic. And as usual, Padmanabhan was what he's talking about. It's as simple as that. And Robert, I liked the way you said that it is not a single point that you have to really look at. You have to look at the whole picture. Like you might think about correcting one thing, and then this might lead to something else. But I think personally in clinical practice that we need to have a broad spectrum of looking at the whole thing, and then sort of try to see what is the problem. This is my take. I totally agree with what you said, and I also agree with what Padmanabhan says about looking at the heel and saying we treat the heel and the back gets okay. But I still feel that we really have to look at the whole picture, and then we get much better results. This is my take. Robert, I stand corrected.
No, you are absolutely right. You're absolutely right. The wider you cast your net, the more chances you have to get it right.
More fishes you catch.
Thank you, Robert. Robert, it was fantastic to have you here. Thanks a lot.
Yes.
Thank you. Thank you.
Thank you very much. Both of you all. Padmanabhan.
Padmanabhan as well. Thank you, Pad. It was wonderful.
Really.
Thank you, BPN family.
Thanks, BPN and I should say Dhananjayan. Hats off to your excellent masterpiece.
It's all what we do. Sir.
Great job. Looking forward in future a similar thing like this.
Definitely.
Thank you for joining. That was very nice of you.
And I think Vinod Jain, would you like to ask something? Vinod Jain, he raised his hand. Yes, Franklin, you want to say? Wait, I have not unmuted. Yeah, Franklin.
Yeah, I had great people here, and I enjoyed the full session in this time. And of course, the news was also good. We are coming out of the lockdown to do all the things.
Not good news.
And not good news.
Not good news.
I disagree. I think it has to be done, especially for the economy. It's extremely important, and it all depends on us now. Anyway, that's now.
Officially, we will just close this. Thanks, moderator. You can just go ahead and then give it to me.
Yeah, sure. Thank you for both the speakers. It was not easy, to get Dr. Robert Lardner, thanks to COVID again. So there is lockdown going on in Chicago. So we could get him. He'll become busy from next week, I suppose. He's starting back in his clinic practice.
We saw the masks.
That's right. They are
So,
a
yeah.
real pain to use.
So we could actually get him. So I think we need to learn a lot. This was only a small gist of what a small thing Dr. Padmanabhan and Dr. Robert had. So I think there is lot to learn from them. We need a whole 1 week or 2 weeks of workshop from both of them. So we look forward for all that. Thank you so much, Dr. Robert, for accepting our invitation and coming. It was a privilege for us to
It
have
was
you.
a privilege for me too.
Yeah, same way to Dr. Padmanabhan. Thank you so much for putting out your brains here so we could get something from you. So much to learn. And thank you so much, guys, for everybody to join in for the bi-monthly meeting. Over to you, Dr. Dhananjay.
Good. It was such a great, amazing session. I understood people with hair and people without hair has more knowledges. Very well. I would like to thank Robert Lander for taking time with this request from Dr. Naveen, and really appreciated for your words and this professional speech. Really appreciated, Robert.
Thank
And
you.
there's no words to say to my maybe my very close, my dada or something, Batmanabhan, who has been always the king of physio community, says that you should be the king. And I really appreciated Batmanabhan's words, who talks more about the professionalism and the profession. Appreciated. And it's also the most successful comes with the participants and the executive, the core committee of the BPN, president and executive president Aarti and then David, Kiran, and all. It was like wonderful presence over this to do it. And people who are watching on the YouTube and who don't have the opportunity to share your questions, you can reach Robert and Batmanabhan on their Facebook pages. I hope they may answer it. Batmanabhan may not answer it, doesn't matter. You just keep asking the questions over there. Okay. And thanks, Robert, and thanks, Batmanabhan. Hereby, we officially close the scientific sessions.
Thank you.
And any participants from Bangalore, would you like to share something, say something?
It's 9 o'clock.
You can just share your need questions in the chat box. We'll take it up. I apologize because of the time concern. I could not get this intro. We got flapped with that. I thought everybody will get 5 seconds to introduce on their own. We had 220 registered numbers. So I think because of this rain or something, they could not reach the place. I think it was a wonderful event. Nandan, would you like to take up any more points to add up here today?
That guy is not around.
Yeah, no, I am there. Robert and Padmanabhan, a fantastic session. We really enjoyed. Thanks for taking the time and doing the same. And we have been. This is the 11th year that Bangalore Physiotherapy Network has been in place, and we have been, open to sharing knowledge to all. And luckily, we had some international speakers here, and we would like to continue have more such sessions in the future. Thanks a lot, Robert. And Padmanabhan, fantastic. You really rocked today. Thanks. And I think we can officially wind up our scientific session, Dhananjay and Naveen.
Yeah,
yes, absolutely.
And you can propose a vote of thanks, and then we can start by having our own dinner and cocktails.
Nandan told everybody should go with the boys. What is it? Booze on your own?
No. Bring your own booze. BYOB.
Yeah.
And bring your own food. BYOF.
That's great. Okay, officially we'll close it up. Naveen, you can go with the vote of thanks. Right.
Thanks.
Bye.
Let me request the participant to stay back even after the vote of thanks. We can have some networking here. Okay.
Yes, absolutely.
Okay.
Yeah. Thank you. Especially I should double thank the core committee of BPN for all the effort, and they come together and it's a family, as Dr. Padmanabhan rightly said. BPN is whole family, and the core committee is always pro info and pro knowledge. I mean, for knowledge sharing. So thanks everybody from Chicago to India, to everybody. I appreciate you took your time and came out. Thanks, Dr. Dhananjay, for hosting it so well. Thank you so much.
Dr. Vinod Babu, would you like to say something?
Yes, please.
Hello, can you hear me, sir?
Yeah, please.
Yeah.
Oh, first of all, I would like to thank BPN committee and organizers for this wonderful session. So without missing the bi-monthly meeting, at least in Zoom, they're done and conducted very well, organized. Thank you, one and all. And also I thank both the speakers. Really, it's a new input to the physiotherapy practice, which is really needed, where our physios are more dependent on electro and exercises.
Yeah.
I hope our both the speakers will come forward with much more detailed training programs in India and in Bangalore that will be helpful for implementing in the clinical practice. Thank both the speakers and thank BPN, and also wish for many more scientific sessions to come up forward. Thank you all.
Thank you.
Thank you. We'll call Robert and put him together with Padmanabhan, and we'll have a workshop.
Okay, thanks. I think thanks, Dr. Bhavanakrishnan and Dr. Sarvana Kumar, for joining all the way for this. Really appreciated. And we could see many were sitting in ideally because of this lockdown, different parts of India's joined here today. Since, as we said, Bangalore Physiotherapy Network is a small group of network. It is not like in other states or other country where we are looking to do it. So we made it that between 6 and 7, it happens only with the Bangalore physiotherapists who are practicing. And then we opened up, and now it is on Facebook Live, which is going on.
YouTube.
Everybody. And officially, we can close this meeting. If anybody has any comments, we'll wait for a few more minutes to open it up. Dr. Sarvana Kumar from Kadlur, you would like to say something? Wait, Sarvana.
Sure, sir.
Yeah, please go ahead, sir.
Before 2018, I am attending the BPN conference with Monakshan sir, but after 1 year, I am in now. It's a very nice experience for me.
Wonderful.
Because of Monakshan sir, only I am here. Thank you for Monakshan sir, Dhananjay sir.
No, it's all the professionals. Okay.
Thank you.
Thank you, sir. Thank you. Great. Thanks, everybody. I think officially we'll close this meeting. Thanks. We'll catch up in the next bi-monthly meeting, if it is online or offline. Thanks for everybody. Thank you. Thanks, Robert, again. Thanks for joining with us. Thank you.
Thank you. Take care.
ನಂದನ್ ಬೂಸ್ಟ್ ಶುರು ಆಯ್ತಾ? ಎಸ್ಕೇಪ್. ನಂದನ್, ಫಾದರ್ ಡೇವಿಡ್.
ಯಾ ಶುರು ಆಯ್ತಪ್ಪ.
ಎಲ್ಲಿ ಗ್ಲಾಸ್
ಗ್ಲಾಸ್ ನೋಡಿದ್ರೆ ಏನೋ ಬರುತ್ತೆ ನಿಮ್ಗೆ.
ಚೇಸ್ ಮಾಡಕ್ಕೆ
ಗ್ಲಾಸ್ ಇದೆಯಪ್ಪ. ವಿಡಿಯೋ ಆನ್ ಮಾಡ್ಕೊಂಡ್ರಪ್ಪ. ನೋಡಿ ಗ್ಲಾಸ್ ಇದೆ, ಶುರು ಮಾಡೋಣ. ಖಾಲಿ ಗ್ಲಾಸ್ ನೀರಿದೆ ಅಷ್ಟೇ.
ಚೇಸ್
ಏನೋ ತೀರ್ಥದ ಗ್ಲಾಸ್ ಇಟ್ಕೊಂಡಿದ್ಯಾ?
ಚೇಸ್ ಮಾಡೋಣ. ಏನೋ ಫಾದರ್ ಡೇವಿಡ್ ಎಲ್ಲದೂ ಕಾಣಿಸ್ತಿಲ್ಲ.
ಕಾರ್ ಒಳಗಿದ್ಯಾನೋ ನೀನು?
ನಾ ವಾಪಸ್ ಹೋಗ್ತಾ ಇನ್ ಮನೆಗೆ. ಇವತ್ತು ಕ್ಲಿನಿಕ್ ಶಿಫ್ಟಿಂಗ್ ಇತ್ತು, ದೊಡ್ಡ ಪ್ಲೇಸ್ಗೆ ಫುಲ್ ಶಿಫ್ಟ್ ಮಾಡ್ಕೊಂಡೆ.
ಕೋವಿಡ್ ಟೈಮಲ್ಲಿ ಶಿಫ್ಟ್ ಮಾಡಿದ್ರೆ ಕೊರೋನಾ ಜೊತೆಗೆ ಬರುತ್ತೆ ಅಲ್ಲ ಅಲ್ಲಿ.
ಯಾವ ಕ್ಲಿನಿಕ್ ಶಿಫ್ಟ್?
ಅಲ್ಲ, ಅದೇ ಕ್ಲಿನಿಕ್ ಯೋಗಾನಂದ ಮುಂದ್ಗಡೆ ದೊಡ್ಡ ಜಾಗ ಕೊಟ್ರು, ಸೊ ಅಲ್ಲಿ ಶಿಫ್ಟ್ ಮಾಡ್ತಾರೆ.
ಎಷ್ಟು ಜಾಗ ಕೊಟ್ಟಿರಪ್ಪ ಮುಂದ್ಗಡೆ?
ನನಗೆ ಒಂದು ಸಪರೇಟ್ ಕ್ಯಾಬಿನ್, ಅಸೆಸ್ಮೆಂಟ್ಗೆ ಎಲ್ಲ ಪ್ಲಸ್ ಟ್ರೀಟ್ಮೆಂಟ್ ರೂಮ್ ಎಲ್ಲ ಅವರೇ ಎಲ್ಲ ಮಾಡಿಸ್ಕೊಟ್ರು. ಅದು ಆಕ್ಚುಲಿ ಮಾರ್ಚ್ ಅಲ್ಲೇ ಆಗ್ಬೇಕಿತ್ತು ಶಿಫ್ಟ್, 2 ತಿಂಗಳು ಡಿಲೇ ಆಗೋಯ್ತು.
ಆಯ್ತಪ್ಪ. ಯಾರಿರೋದು? ಸಂಜೀವ್ ಪ್ರಭು, ಶ್ರೀನಿವಾಸ್ ಪ್ರಸಾದ್, ರಾಧಾ, ಐಫೋನ್ ಗ್ಯಾಲಕ್ಸಿ, ಮೋಹನ್ ಸರ್ ಇವರ್ ದೇರ್. ಶಶಿ ಕುಮಾರ್, ಯಾರಿದು? ಗ್ಯಾಲಕ್ಸಿ ಅಲ್ಲ, ಗ್ಯಾಲಕ್ಸಿ J7 Pro, ಗ್ಯಾಲಕ್ಸಿ J.
ನೀನ್ ತೆಗಿಬಹುದು.
ಹೆಸರು ಹಾಕಪ್ಪ.
ಟೀಮ್ ಇಲ್ದೇ ಇರೋರ್ನ ರಿಮೂವ್ ಮಾಡ್ಬಿಡು.
ಇಲ್ಲ, ನೆಟ್ವರ್ಕ್ ಮಾಡಕ್ಕೆ ಅಟ್ಲೀಸ್ಟ್ ದೇ ಶುಡ್ ರೀನೇಮ್ ಇಟ್ ಆರ್ ಆಸ್ಕ್ ಟು ಸ್ಟಾರ್ಟ್ ದ ವಿಡಿಯೋ ಇಫ್ ಯು ವಾಂಟ್ ಟು ನೆಟ್ವರ್ಕ್.
ಇನ್ನು ಲೈವ್ ಯೂಟ್ಯೂಬ್ ಅಲ್ಲಿ ನಡೀತಾ ಇದೆಯಪ್ಪ, ಅದನ್ನ ಆಫ್ ಮಾಡಪ್ಪ.